and welcome. I'm Catherine Banwell, your host for today's program. Today, we're going to discuss how to access the most personalized therapy for your MPN and how you might benefit from key testing. Finally, before we get into the discussion, please remember that this program is not a substitute for seeking medical advice. Please refer to your healthcare team about what might be best for you. All right, let's meet our guest today. Joining me is Dr. John Mascarenhas. Welcome. Would you please introduce yourself?
Thanks for having me. My name is John Mascarenhas. I'm an associate professor at the Icahn School of Medicine here at Mount Sinai in New York City. And I am a clinical investigator in Myelofibrosis neoplasms, and I direct the adult leukemia program here.
Excellent. Thank you so much for taking the time out of your busy schedule to join us today. Before we delve into our discussion, let's start with a term we've been hearing a lot about recently. How would you define personalized medicine?
So it's a good question because I think it's poorly defined in many ways because it can mean different things, I think, to different people. And it's a definition that's in evolution. So I think at its core, personalized medicine tries to embody the concept of creating an evaluation and management plan that is specific or tailored to that patient on multiple levels, on a personal level, on a objective level of what the patient's objectives are with their therapy or their disease, and then on a biologic level in terms of the type of disease, and now increasingly on a molecular level. So in some cases, it may be personalized therapeutics that are specific or targeted to certain mutations that the patient may have. And that's kind of where things are evolving from a treatment perspective. But to me, personalized medicine should be the goal of any interaction with a patient, that you have to personalize the approach because every patient that we meet is quite different and distinct from the next patient, and their own sensitivities, understandings, and desires could be quite different. So you want to personalize that approach to that patient at the most basic level.
Yeah. Well, that's really helpful as we move through today's program, which is going to cover the three classic MPNs: Polycythemia Vera, essential thrombocythemia, and myelofibrosis. So for someone who has one of these conditions, can you help us understand how one may progress to the next?
So these are a very heterogeneous, variable group of diseases that are under an umbrella called the myelofibrosis neoplasm. So MPNs can really present and behave and have very different clinical courses. So I think it's very important for patients to realize that these are rare diseases. That adds a complexity to it because they don't always have the ability, the privilege to know other patients or people in their lives that may have these diseases. So it can be very frightening from a level of feeling isolated or alone with a diagnosis like this and not having familiarity. But also that these are vague diagnoses in the sense that when you have breast cancer, one can kind of conceptualize that there's a mass in the breast, for example, and that could be staged. It can go to the lymph nodes in the armpit. It could spread below, and people can kind of understand that concept. I think it's a little bit more challenging when you talk about MPNs because it's a little bit more abstract. These diseases are within the bone marrows at diagnosis, so they're not staged in a physical way. And they are complex because they can lead to high blood counts, low blood counts, different types of symptoms, and the approaches really have to be personalized. They are all three interrelated because there are commonalities. So there are certain clinical commonalities and also biologic commonalities. So for example, the JAK2 mutation, the JAK2 V617F mutation is seen in all three diseases. So it's not specific to one or the other. Is more common in Polycythemia Vera, but in about 50% of patients with ET and 50% of patients with MF, you can see this mutation. So the mutation alone doesn't really tell us what the disease is. It just tells us you have one of these diseases, and there are other mutations. So bone marrow biopsy really becomes integral in helping subtype the patient and then create that treatment plan and that outlook that's specific for that disease. And as you mentioned, to make it even more complicated, these diseases can overlap, not just biologically, but in a continuum. So patients with ET or Polycythemia Vera can progress, in some cases, to myelofibrosis. And all three diseases in a minority of patients can progress or evolve into an acute myeloid leukemia, which is a more aggressive form of bone marrow cancer.
Yeah. Well, let's turn to testing. And you did just mention this. You touched on it a moment ago. What tests are necessary to help understand a patient's specific disease at diagnosis?
Usually the blood counts are the first sort of the opening door test that allows some understanding of again, either an abnormal production of red cells, platelets, or underproduction of these cells. And that's really where often the evaluation begins. And then there are further blood tests that often are done, and I would say almost indefinitely or almost definitely one should have a bone marrow biopsy that helps categorize the type of myeloproliferative neoplasm, because there can be overlap in how the blood counts can look from one disease to the next, and overlap in the mutations like the JAK2 mutation. So sometimes the blood counts and the molecular testing are not enough, and a bone marrow biopsy looking under the microscope at the different types of cells, the proportion of cells, whether there's fibrosis, whether there's other types of cells that shouldn't be there, and then looking at the chromosomes and the flow cytometry. These are associated tests, as well as almost probably anywhere anyone goes at this point, they're going to get next generation sequencing, which is looking at multiple genes and mutations, and that gives a more broader, deeper sense of the disease. So that those really become the integral parts. In some cases, patients will end up getting imaging of their abdomen to see if they have an enlarged spleen or enlarged liver, although that's not always necessary. That is often part of the workup. So it's blood work, it's bone marrow biopsy, sometimes imaging is usually the cornerstone.
Oh, and what is molecular or biomarker testing?
So molecular testing today really means, at one point it really meant looking at PCR for specific gene mutations. So for example, we would look at the JAK2 and we would say, in a given person, is this gene mutated? We all have a JAK2 gene, but in patients with these diseases, they're more commonly mutated, which means altered in the blood cells. And it's very important for patients to understand, not in every cell in their body, but in their blood cell compartment. And that helps us understand and start characterizing their disease. And sometimes that mutation can be measured. It can be at a low level, it can be at a high level. And that's all put together in trying to understand the molecular basis of these diseases. Today, next generation sequencing is really taken over, and that's looking at more than just one gene. It's sequencing, it could be 40 genes, it could be 200 genes, to get a sense of the complexity of the disease and looking for certain mutations, which are considered biomarkers that can portend prognosis, or I think increasingly we'll see may inform treatment decisions and may even be targets themselves of therapies.
Right. Should all patients diagnosed with ET, PV, or MF undergo biomarker testing? Is that necessary?
I think I would say it's part of the modern evaluation and management of patients today. I don't think that was true 10 years ago, but I think the field has matured. I will say, and I'm the first person to acknowledge to patients, that we get a lot of information back. And the truth is, we don't often know what to do with all of that information. So sometimes we get information back that can cause anxiety because you can see mutations in genes, but they don't always inform us on how to educate the patient about their disease or tell us what to do with the treatment. So there's still a lag, as there normally would be, between the testing and the results that we get and then the actual knowledge of what to do with that. And that's still a process that's in evolution.
Right. Some patients may not know if they've received these important tests. So what key questions should they ask their physician about testing?
Well, I think it's important that the patients feel empowered to understand sort of where the field is and what key questions you would ask a physician hematologist who's taking care of you. So, I think all patients should be aware of their diagnosis, the name of the diagnosis, the subtype, but also, do they have any of the key driver mutations, the JAK2 mutation, the calreticulin mutation, the MPL mutation, and that's usually done off of a bone marrow biopsy sample, but can be done off peripheral blood. And they may not always know that it's done. So I think having a discussion with the physician to understand, there are criteria that exist called the World Health Organization criteria that are updated frequently. and should set a standard throughout the world of how you diagnose and establish these diagnoses. So I think it's important for physicians to be able to convey to the patients with confidence, we follow these criteria and you have these criteria, and we've done this testing that shows that you have these mutations, and not just regurgitate what they found, but help them understand and navigate what that means, which, again, I will point out that sometimes we don't know, but I think it's important for physicians to convey sometimes that some of the findings that they may see, for example, patients look on portals these days and they can look at their labs and stuff like that. We don't always have a terrific answer or an informed answer for everything that we get back. And that we will potentially in 10 years from now, but sometimes at the moment we don't. But I think a discussion about the meaning of the labs that are obtained is probably good for the patient to understand what's being done.
Absolutely. It sounds like each person's situation is unique and should be considered before making any treatment choices. Can you talk about how the results of these tests may affect prognosis and treatment?
So we do use, we have risk stratification systems that we use for essential thrombocythemia, polycythemia, Vera, and myelofibrosis. I'll talk about myelofibrosis because that's probably a little bit more of a complex and sophisticated model that's also changing, and we update it frequently. And these models are imperfect, so I always warn patients to not put all of their their money in one basket when we talk about risk stratification. They broadly help us understand where a patient is in their disease course. So, for example, in myelofibrosis, historically, the DIPS, the Dynamic International Prognostic Scoring System, was used, which considered 5 clinical variables that have been shown to be independently prognostic. So, age over 65, the presence of blasts or circulating immature cells in the peripheral blood, anemia, hemoglobin less than 10, symptoms, fevers, night sweats, weight loss, or high white count over 25,000. You add those points up, and patients can do this online. There are calculators that you can calculate your DIP score, and you'll see that there are 4 different risk groups that range from low risk to high risk, and they are associated with median survivals. We now know that mutations influence those, have influence on prognosis. So there are a group of high molecular risk mutations like ASXL1, SRSF2, IDH1 and 2. So there are mutations that also have prognostic significance, and we incorporate them into the decision making. And essentially, and this is where I think patients have to be very careful, physicians have to be very careful in conveying this. With these risk models, whether they are clinical variable risk models or these integrated molecular risk models, each category is associated with a median survival that's based on retrospective studies, but that doesn't tell the patient specifically what they should expect in terms of survival. And I always fear that patients, when they look at these things, or even physicians when they convey them, that they may inadvertently misrepresent or convey what those really mean. I think the purpose of those risk stratification tools is really to help guide a risk-adapted treatment approach that's reasonable and is weighted for benefit to risk of the disease. So, for example, if you have advanced disease with a high risk score of intermediate 2 or higher, bone marrow transplant in certain patients may be a warranted therapy to consider. So they really help inform treatment.
Right. You mentioned a couple of these already, but outside of testing, what other factors should be considered when choosing treatment?
I think patient expectation. So, sometimes physicians and family will impose what they want for a patient, and that may not be what the patient really wants. So I have learned over the years that it's crucial to make sure that you understand the patient and what the patient's expectations, desires, and that's influenced by the life that they've led, or the remaining life that they want to live, and their own personal, religious, and spiritual beliefs. So I think knowing your patient and understanding what their expectation is it's fundamental, and sometimes it's overlooked. So understanding that, I think, is very crucial. And then defining what are the objectives of the treatment. In any given patient, is it really to improve anemia in some patient, versus perhaps in a different patient, it may be to improve their quality of life and reduce their symptom burden. And then in other patients, it may be purely trying to cure the disease with therapies that may be aggressive, which may not be appropriate for an older patient, where toxicity could outweigh any potential benefit of survival or longevity. So you really have to have a discussion with the patient, their caregivers, and then define what are the goals in that individual to personalize that approach for that patient.
Right. And there's the patient's overall health, comorbidities, other things like that.
Yeah, because we're not treating a disease in isolation usually. So patients come with baggage of past diseases, current diseases, and sometimes patients are not quote unquote fit for certain types of therapies because they may be sick or they may have organ dysfunction that would make certain types of treatment approaches ill-advised because the toxicity could be higher. So it's absolutely, you need to know their comorbid index, how much comorbidities they have, and also their performance status, how active and how well they are in general.
Right. Are there specific biomarkers that may affect prognosis or treatment?
So yes and no. I mean, I think that's an area of intense interest and research. So we have identified certain biomarkers that have, as I mentioned, prognostic significance, and that may influence treatment decisions. So patients who have, for example, as we discussed, next generation sequencing, and we see their mutations that are present, if they have an accumulation of high molecular risk mutations, that may give us a sense that perhaps that patient may not enjoy the full benefit and duration of benefit of, for example, a JAK inhibitor as another patient that has a less complex disease. And that doesn't necessarily mean that the therapy is not appropriate for the patient, but it may help us plan and be prepared to move on to the next therapy sooner, or to be more vigilant for changes that would tell us it's time to move on. So I think they help us maybe get a general sense of things and put things into perspective. They don't always necessarily inform us on a change in therapy immediately or the next or the most immediate therapy. But I do think that will change, because I would predict in the next 5 to 10 years, I think that the number of available drugs for myelofibrosis, for example, will likely double from what it is now. I think we will have an armamentarium to choose from. And what we will learn from trials that are ongoing is there may be certain profiles, mutations, chromosomal profiles, other clinical variable profiles that we will learn from these trials that will help us define upfront, well, this profile really should go with this medication, that profile should go with that medication. An early example of that would be, we're learning that not all patients with a JAK2 mutation are created equal, that you can have different burdens of JAK2 mutation, and patients with low burden JAK2 mutation, for example, may fare better with a specific JAK inhibitor like pacritinib than patients who get treated with other JAK inhibitors like ruxolitinib. So there are differences even within patients defined by mutation that may help us predict which of the JAK inhibitors, as an example, may be more appropriate as first-line therapy. So I think that will evolve more so over the next 5 to 10 years.
Yeah. Dr. Mascarenhas, what is inhibitor therapy and how does that work?
So inhibitor therapy in general are usually they're oral drugs for the most part, small molecule inhibitors that are geared and usually specific, but not totally specific, because they can have off-target effects, but geared to inhibiting usually an enzyme that is overactive or is contributing to the pathophysiology of the disease. I think in MF, probably one of the best examples is JAK2 inhibitors. So there are a number of JAK2 inhibitors that have been in clinical testing. There are 2 that are approved, ruxolitinib and fedratinib, which are excellent drugs in inhibiting JAK2 protein itself in the cells that could be either upregulated or hyperactive in the signaling pathway, and it quiets down a signaling pathway in the hematopoietic cells that leads to a lot of the manifestations of the disease, namely symptoms and spleen. So one of the clear benefits of JAK inhibitors that was established many years ago and reinforced by multiple drugs that are either approved or in late stage testing is these drugs are excellent in improving the symptom burden of patients and reducing their spleen. Unfortunately, as a class, we've not seen these drugs induce remissions or cure patients. So there's still interest in developing, obviously, non-JAK inhibitor therapies, but inhibitors in general are inhibiting proteins that are either inappropriately activated or part of a cascade of signaling molecules that are contributing to the disease. And they are not chemotherapeutic, which might be an important point to make. In past days, we've relied heavily in hematologic malignancies in using chemotherapies, which are nonspecific and just kill dividing cells, whereas inhibitors typically are targeted and in some senses personalized to the disease with toxicity profiles that are usually quite distinct from the traditional chemotherapies that we used.
Mm-hmm. Well, outside of inhibitor therapy, let's review other treatments for patients. Depending on the patient, it seems like ET or PV may be easily managed. So how are they treated? Let's start with essential thrombocythemia, or ET.
So ET is a disease in which, first and foremost, we're trying to reduce the risk of thrombosis, clotting, and or hemorrhage, bleeding. So typically ET patients are risk stratified by low risk or high risk. It's almost simply based on their age, whether they've had a clot in the past. Mm-hmm. And some systems now even incorporate other factors like mutation status. And you tailor the treatment based on their risk score. So low risk ET patients don't necessarily need to be treated. They can be followed expectantly and watched. The height of the platelet count does not predict thrombotic risk, so we don't treat the platelet count per se. A high risk patient is at high risk for clotting. So these patients almost invariably are getting aspirin at a baseline, and they are often on cytoreductive therapy. And sometimes that is chemotherapy, like hydroxyurea. Sometimes it's a non-chemotherapeutic option like anagrelide. And sometimes it's a biologic therapy like interferon alpha, either 2A, Pegasus, or 2B, ropeg interferon. And these are therapies that have rationale, that have clinical data, that have demonstrated reduction in risk of clotting, which again is the reason why we treat higher risk ET patients.
Yeah. And what about PV, polycythemia vera?
So in polycythemia vera, it's similar to ET. We risk stratify patients low and high risk based on age and clotting history. In whether you're low risk or high risk, we give PV patients aspirin at least once daily, and we look to keep their hematocrit below a threshold of 45%, and sometimes in women we even go lower to 42%. But the idea is that controlling the hematocrit, which is one of the red blood cell indices, you reduce the risk of having clots, and that's been shown actually many years ago and reinforced. And a very well-known study called the CytoPV study in Italy documented that if you keep a hematocrit less than 45%, so stringent control versus allowing for less stringent control between 45 to 50, that you reduce by fourfold the number of cardiovascular events that can occur. So we know that controlling the hematocrit is important, and that can be done again with hydroxyurea, interferon, and ruxolitinib, the JAK2 inhibitor, is also approved specifically for patients who have intolerance or refractory to hydroxyurea, but also importantly as a drug that can address, probably better than most drugs in this field, the symptom burden that can be problematic for some of those patients. But it's really about controlling the hematocrit.
Yeah. Since myelofibrosis is a progressive condition, I imagine that makes it more difficult to manage. So what else is available for patients with myelofibrosis?
The first line of treatment is typically a JAK inhibitor, although I would say that there are a subset of patients. There are patients you sometimes meet that have very low risk disease. They don't have those clinical variables we discussed before that could uptick their risk score. And some of those patients can be watched. And interestingly, there are a subset of patients that can have an indolent or slow form of the disease where they don't have aggressive changes in their disease, their blood counts, their symptoms, their spleen, and don't need immediate treatment. Most patients would benefit from a JAK inhibitor, although there are a subset of patients where their issue is less symptom and spleen burden, and it's more anemia. So we take those patients where anemia is the focus. We look at their erythropoietin level, which is their endogenous hormone level that regulates red blood cell production. If it's low, we give them a lab-based form of erythropoietin, something called Procrit or Aranesp. If it's high, we will move on. We can use a drug called danazol, which is a synthetic male androgen, which can improve hemoglobin levels 20 to 40% of patients. Or we will use a drug called lenalidomide, which is an immunomodulatory drug. And more recently, there's a drug in testing called luspatercept, which is an activin ligand trap. So there are a growing armamentarium of drugs that can be used to try to alleviate the anemia, which is present in and can be a significant issue in about a quarter of patients with myelofibrosis up front at time of diagnosis, or about 75% through the course of their disease. So that's an unmet need that still requires attention and may alter the treatment plan for a given patient.
What about stem cell transplants?
So we relegate stem cell transplant for those patients, as mentioned before, that are higher risk, because we think that the potential benefit to risk ratio is in favor of transplant. Transplant is really a modality that is the only modality that offers the potential for cure, but it's also a modality that holds a significant risk of morbidity and mortality associated with it. So it has to really be taken very seriously. It can't be kind of treatment you would think of as a last resort at the last minute. It has to, one should see a transplanter if they're interested in that therapy, and see it early on in the disease course, in my opinion, to start that dialogue, and then figure out when is the optimal time to employ a bone marrow transplant, which is not a surgical procedure. It's often thought to be surgical. It's not a transplant of an organ, it's a transplant of hematopoietic cells. So it's really an infusion of stem cells that then end up in the person's bone marrow and then create a whole new hematopoietic system and immune system. And with that, you can have an immune system that then goes after the myelofibrosis stem cells. That's called graft versus leukemia effect. But with that, you can get graft versus host disease, which is when the new graft, the new immune system, doesn't always recognize well the person's own tissues, whether it's the liver or the lung or the skin, and you can have immunologic reactions to that. So that's a complex discussion, but transplant typically for patients less than 70 years of age who have higher risk myelofibrosis, or even up to 75 if they have a good performance status, and as we said, don't have a lot of comorbid issues, with a goal of cure. So if you have someone where their goal is to try to maximize their time out of the hospital, and they're not focused on longevity, they're focused on quality of life, that may not be an appropriate patient for transplantation. So I think a very upfront, honest, and a transparent discussion with the patient about what to expect with transplant, what are the pros and cons, what are the risks involved, and importantly, does it match up with their expectations or their desires?
Right. We have a question from Mike that we received prior to the program. He wants to know, what does it mean to have high-risk myelofibrosis?
So high risk can be defined different ways. For example, if you're using the DIP score, it means that you have enough of those points to put you in a category that would suggest that your disease is more likely in a shorter time period to cause significant morbidity and mortality than someone who has low risk disease. So it's really, as we said before, we don't stage myelofibrosis like stage 1, 2, 3, and 4 metastatic disease, but we risk stratify patients. We put them in these categories, and that helps us decide what treatments may be more appropriate. And as we were discussing, transplant is a therapy if you're a high-risk patient and you're inclined and you don't have a lot of comorbidities, and you're not very advanced in age. That may be a treatment that is appropriate for a high-risk patient, a high risk for having a bad outcome with the disease within a shorter period of time.
Right. And we have another question from Craig that we received earlier. I'm currently receiving regular phlebotomies for PV, but my doctor is considering switching me to inhibitor therapy. What can I expect? And are there side effects that I should be concerned about?
So for some patients, therapeutic phlebotomy is all that they need, and they do very well with it, and they don't need to take a therapeutic like a JAK inhibitor or hydroxyurea, which is a non-specific treatment. But some patients do. So some patients where if their risk score is higher and their risk for thrombosis, that may be an appropriate indication. And some patients have a lot of symptoms with their PV. So not all PV patients present and behave the same way. Some patients have a very low symptom burden. Some patients have a very significant symptom burden. Itching, for example, can be a very annoying and very troublesome symptom for patients with PV. And if you don't have PV or you don't know someone with PV, you may not understand or realize the negative impact of having intractable itching, often associated with taking a shower or warm water. And that can really detract from quality of life and cause a lot of anxiety. So that's an example where sometimes a JAK inhibitor like ruxolitinib can be really life-saving in terms of restoring quality of life and functionality to a patient. Usually drugs like ruxolitinib are very well tolerated too, which we're fortunate about. There's not a lot of toxicity associated with them. So for example, nausea, vomiting, diarrhea, hair falling out with chemotherapeutics, you really don't see with ruxolitinib or Jakafi. Easy bruising, headaches, some dizziness up front sometimes can be seen. They're usually low grade and they're usually fleeting. And usually the benefit, the feel-good aspect of it outweighs toxicity that can be seen with the drugs. They are immunomodulatory drugs. So ruxolitinib or Jakafi may increase to some small extent, but likely real extent, infectious complications like shingles, urinary tract infections, upper respiratory infections. So sometimes there is this increased risk. It's often outweighed by the benefit of the drug. But there are risks that are associated. And they're not, of course, these risks are not guaranteed. So I always warn patients, be careful when you look at the package inserts or talk to the physicians. Risks are risks. They're not guaranteed. So most patients don't have these toxicities, but one is at risk for a toxicity whenever they take any medication.
Yeah. Before we close, Dr. Mascarenhas, let's talk about research. Are there new developments that you're excited about?
Yeah, absolutely. So what I'm heavily interested in and involved in is clinical investigation and moving the field forward. And there are many people out there that are similarly involved and are doing really excellent work. So I am super jazzed and enthusiastic and optimistic. And it's what gets me to work every day and inspires me is all the effort that is happening. And it's a continuum. So it's not just one person trying to try a different drug here and there. It's really bringing together many different people, because these are rare diseases, many different people from many different institutions that have different areas of expertise, but have a common goal of translating from laboratory informed data. So not just taking a dart and throwing it at the dartboard and hoping it sticks, but actually taking data that we learn from the lab, leveraging that information to develop therapies that are informed, that are targeted, that are personalized, and going through a process of evaluating them to get them into the clinic with the goal of, and I would say ambitiously, our goal these days is moving beyond trying to make patients feel better, which is an important goal, but it's really, can we really target the disease in a more effective way to induce remissions, to, dare I say, cure patients? So I think the ambitious goal of the clinical investigators and laboratory investigators that are active in MPN research today is really one looking for understanding at the basis the biology of the disease to develop curative therapies. And I am optimistic that will happen. And I don't mean happen in 100 years from now, it happen in our lifetime. So that's where we're going. There's a lot of very exciting drugs, oral and intravenous drugs that target very different types of aspects of the disease. And I think patients and physicians will see that many of those drugs are used best in combination. So the idea of using one drug, waiting for it to fail, and then using another drug is really old news. And much of oncology is combination therapy. So taking drugs that have differing targets or mechanism of action and non-overlapping toxicities to try to better target and delete what's called the myelofibrosis stem cell. That's the basic issue here, which we don't effectively delete other than transplant. So our goal would be to put bone marrow transplanters out of business.
Well, that's a great plan. I hope that can happen one day. Thank you so much for joining us today, Dr. Mascarenhas. We appreciate you taking the time.
My pleasure.
And thank you to all of our partners. To learn more about MPNs and to access tools to help you become a proactive patient, visit powerfulpatients.org. I'm Catherine Banwell. Thanks for joining us today.